everybody, this is Tim Horton, and I'm going to be presenting on schizophrenia and psychotic disorders. I'm really excited about this presentation today because this is some of the more serious mental illnesses that we'll be studying, and this is where things really get interesting, I think. Not that the other things aren't interesting, but these are particularly complex. So what are the objectives of today's lecture? The objectives are to understand the basic signs and symptoms of psychosis and potential physiological causes, to understand the diagnosis of schizophrenia and other psychotic disorders, to understand the dopamine hypothesis, as well as novel treatments of schizophrenia, to understand the phases of schizophrenia, to understand the treatment of schizophrenia through the use of various algorithms and assessment tools, and to understand the various medication considerations of atypical antipsychotics, as well as antipsychotics in general, as well as the potential side effects. So to start, what is psychosis? Psychosis is not a disorder in and of itself, but rather a description of many different phenomena that involve problems or breaks with reality. So the way that the person sees the world around them is not correct. This can include abnormal sensations, catatonia, behaviors, as well as thought disorders. This can also include problems with a person's sense of reality, in which they have a hard time making sense of the world around them. Primary symptoms of psychosis often include hallucinations, delusions, trouble organizing thoughts and speech, and disorganized behavior. The symptoms of psychosis can be caused by a whole different set of brain conditions. And on that note, as APRNs, we must examine the various differential diagnoses in treating our patients to make sure what we are seeing is actually psychosis, as there can be a whole bunch of medical origins of psychosis as well as drug-induced psychosis. The two main ones that I think of are the little old lady that has the UTI and all of a sudden is become aggressive as well as psychotic, or maybe meth use and how this, sometimes very slowly creates a sense of psychosis. So what is schizophrenia? Schizophrenia is a neurodevelopmental disorder that includes disturbances in perception, emotion, executive cognitive function, and problem and social relatedness. And it impacts between 0.3 and 0.7% of people in the United States. In men and boys, it usually starts between 15 and 25, and in women and girls between 20 and 30. So the onset is usually a little bit earlier in men and boys. Early onset schizophrenia begins earlier but is rare before the age of 13. And etiology is best described by neurodevelopmental models with various genetic risk factors, such as multiple mutations and multiple genes and loci with various genes. Environmental factors can impact those genes, as well as the brain itself, and these can include in utero exposure, famine and pregnancy, advanced paternal age. So they found a big pattern with as the dad gets older, essentially, his children have an increased risk of schizophrenia. I found that really interesting. As well as environmental factors can include marijuana use. We're seeing a big increase with the legalization of marijuana, and so the authors of our text make the argument that this might be why there's an increase in psychosis as well. And then we have prenatal infections and direct neurological damage that can cause problems with the brain. So what is likely to cause a schizophrenia? It's usually probably a whole bunch of these factors coming together. So we probably have a whole bunch of these genes for schizophrenia, some of us more than others, if we have a genetic predisposition, and then maybe they're expressed because of certain things. So what are the symptoms of schizophrenia? The primary symptoms include autism, ambivalence, affective disturbance, and loosening of associations. And secondary symptoms include the illusions, delusions, hallucinations, symptoms related to muscular activity, withdrawal, and lack of touch with reality. So we can think of the positive symptoms as the delusions, hallucinations, disorganized thinking, and the negative symptoms including the cognitive, affective, and social functions, as well as the blunting and social withdrawal. I always think of the positive symptoms as the things that we're adding onto somebody's brain, and the negative symptoms are the things that unfortunately we're taking away, that blunting, we're taking away their social drive, etc. What do we know? The causes of psychosis and schizophrenia. We know that psychosis is an impairment of brain function resulting from various symptoms, most likely a result of genetic and neuroanatomical abnormalities. We know that physical changes are evident with the brain in people with schizophrenia, whether it's an MRI scan or a CT scan. People that have had schizophrenia for a long time actually show shrinkage in various parts of the brain. We also know that identical and fraternal twins have an increased incidence of schizophrenia, in particular identical twins. We also know that early onset of schizophrenia may result in greater neuroanatomical abnormalities causing greater disability. And we know from our other classes as well that antipsychotics might be neuroprotective to help prevent some of these changes. Finally, we know that there's a greater contribution to schizophrenia, a genetic contribution to schizophrenia, which is implicated in about 60% of the cases of schizophrenia. So, one of the main hypotheses of the causes of schizophrenia is the dopamine hypothesis. This is where there's an altered activation of dopamine receptors, and this causes the schizophrenia. There's dysregulation of the dopamine neurotransmitters, which is a common theme in animal studies in schizophrenia. There's hyperactivity a lot of times in the limbic region of the brain, and the mesolimbic pathway, which causes the positive symptoms. And we know that there's hypoactivity in the frontal regions of the brain, and the mesocortical pathways, which cause the negative and affective symptoms. So we know that it's hypo and hyperactivity of dopamine, essentially, that causes schizophrenia. Regulatory feedback loops impact serotonergic, GABAergic, and dopaminergic neurotransmitters. So we have the dopamine hypothesis as the main hypothesis for schizophrenia and what causes it, but we also know that there are feedback loops and all of these pathways are interrelated in the brain and interconnected. So for all of you that were missing the Stahl textbook, or for those of you who thought, you would never see these slides again in a PowerPoint, well, here they are. So what we think of in schizophrenia, if you're going to deconstruct the symptom or deconstruct the syndrome, is we deconstruct it into symptoms. The positive symptoms being delusions and hallucinations, and the negative symptoms being apathy, anhedonia, cognitive blunting, and neuroleptic dysphoria. It is thought that there are malfunctioning circuits within the brain, so particular parts of the brain that malfunction that cause certain symptoms that we see in a person. So maybe their aggressive symptoms are caused by the orbital frontal cortex and the amygdala, kind of that animal brain. We talked about the mesolimbic and the positive symptoms, etc. But it's deconstructed in a neat little picture there for you. And just a little reminder from the Stahl text. So the dopamine hypothesis continued. For D2, there's an upregulation a lot of times with the D2 high receptors, which is consistent in schizophrenia, and this is most actively impacted by traditional antipsychotics. In D3, there's an alteration in D3 receptor activity, which has also been implicated in schizophrenia and more of the cognitive symptoms. The D3 receptors a lot of times have a higher affinity for dopamine, and smaller changes in this receptor activity may change synaptic transmission. The location of this is usually in the accumbens, thalamus, hippocampus, and cortex. And we know that D3 has the higher affinity of dopamine, which may cause the cognitive dysfunction. And this is more impacted by the novel, newer antipsychotics. So in the right-hand picture here, you'll see the mesolimbic overactivity, and this causing the positive symptoms with the little alien guys there. I always thought that was cute when I was reading the book. So we also know that those negative symptoms can be explained by the dopamine hypothesis. So we have the mesocortical dopamine hypothesis of cognitive, negative, and affective symptoms of schizophrenia. This is also from your Stahl textbook, essentially where we only have a little bit of those dopamine receptors being filled with the dopamine, and so this causes this cognitive blunting, etc. We also know that the dopamine hypothesis is most likely too simple to explain all the different manifestations and all the reasons someone gets schizophrenia, but we think that the core pathophysiology is related to dopamine. However, there's growing evidence that shows that alterations in glutamatergic, serotonergic, and GABA can lead to dysfunction in interneurons. And like we mentioned, this can lead to more of that cognitive, behavioral, and social dysfunction. And we also know that the dopaminergic system interacts with all these other symptoms. So everything's interconnected, and it's just much too simple to say, well, it's all the problems with schizophrenia are caused by dopamine. So some little graph here that I thought was really neat. Some novel treatments for schizophrenia. So we know that D2 blockade a lot of times is going to be helping with those positive symptoms of schizophrenia and really help a person return to baseline. But we can also target different areas. We can target glutamate, serotonin, acetylcholine, GABA, and then we can target the inflammation within the brain. If we target all these different areas, we might see improvement in other symptoms. So Yang and Tsai are saying that if we target glutamate and the MDAR and AMPA receptors, this may improve negative symptoms, and their studies related to that. And then we know if we target serotonin through our atypicals, a lot of time in particular Abilify, with the 5-HT1A, etc., we'll get a reduction in extrapyramidal side effects with, the atypicals. That's why they're a lot of times better tolerated. And a lot of times we'll get improvement in those cognitive impairments, as well as potential treatment of different phases of the illness. We can target acetylcholine with the muscarinic agonists and positive allosteric modulators. And then we can target the GABA and the cytokines, as well as inflammation within the brain. So there's a whole bunch of different studies targeting each one of these areas in hopes that we can get novel treatments for schizophrenia other than, the D2 blockade, that we can really hopefully improve people's lives with schizophrenia. So I included that just as a little, extra tidbit. I think as time goes on, we're going to see more medicines, and I think it's good to maybe return to this and return to the research to understand how they work, especially with like Rexulti and Latuda and certain other things. It's good to have that in the back of your brain. So the breakdown of these novel treatments, we now know that the D2 antagonists are not the only solution to treating schizophrenia. If we really want to make our schizophrenic patients have a more normal life, we know that the D2 and D3 agonists, such as Abilify, may help with medication adherence, as well as social interactions, which might be a protective factor. We know that glutamate and glutamatergic dysfunction has been implicated in schizophrenia, and we have medications that can treat that. We also know that blockade and agonists of certain serotonin receptors may also improve negative symptoms. We know that benzodiazepines may help as an augment for antipsychotic, to antipsychotics. We know that cholinergic agonists have a positive cognitive effect. So this is a lot of times why they think that schizophrenic people smoke. They get a little bit of a positive cognitive affect from it. And we also know that there are inflammatory processes going on when it comes to schizophrenia. And there's no definitive benefit in schizophrenic patients proven in getting rid of some of this anti-inflammation, but it's thought if we can treat the inflammation that it would be neuroprotective. So we have schizophrenia, and all of us know that schizophrenia just doesn't happen all the time. Even though there might be a patient in front of you that's acutely psychotic, it probably happened essentially over time. So we know that there's the prodromal stage, which is a gradual and insidious onset of schizophrenia, including subtle changes in behavior, increasing isolation and withdrawal. I always think back to a patient that I had at Prairie Care that all of a sudden was acting really odd. She started running away from home. She went from an A to a D student. She dropped out of all of her sports activities. She just started hanging out in her room. She didn't want to go anywhere. And it was thought that this maybe was related to some prodromal schizophrenia. Schizophrenia ran in her family, unfortunately. Some assessment techniques. We always need to remember we can't always trust the patient 100%, as best we can. We also have to get a context for their life. So asking loved ones and friends about how someone has been doing if you're suspecting schizophrenia will really help put things into context. If you're having a patient that is prodromal, a lot of times they might be a little bit paranoid and they might not want to talk to you. But if you ask questions a little bit in an open-minded way, like if their eyes and ears are beginning to play tricks on them, maybe that can kind of help them be honest. So once they've moved past the prodromal stage, and a lot of times that happens in the late teens, like I mentioned with the patient I just spoke about, we get to an active phase. And this is the beginning of psychotic symptoms, including hallucinations, delusions, or problems in speech and behavior. Auditory hallucinations are the most common positive symptom. So a lot of times we get the patient, unfortunately, that can't speak, can't take care of themselves. A lot of times this is a signature of this is the presence of the 4A's, loose associations, affect, autism, and ambivalence, as we spoke about. For a DSM diagnosis, it requires hallucinations, delusions, or disorganized speech for at least 1 month. So they have to be a little bit more long term. So once we've treated the active phase and some of those positive symptoms abate, we get into a residual phase where the active symptoms are no longer prominent, but negative symptoms and problems in life functioning are usually more notable. So we've treated the hallucinations, but unfortunately that blunted affect, that inability to have a job because they can't socialize, the slowing down of their thought process, all these other things tend to kind of unfortunately hang around because they're harder to treat. Hopefully, as we talked about, as novel treatments become more advanced, we'll be able to treat more of those negative symptoms in that residual phase. So when we're assessing psychosis, we always need to make sure that we're assessing the onset, duration, and symptoms. And then we need to make sure that we're ruling out the medical illnesses, including tumors, masses, and lesions, substance abuse, medication, adverse effects, endocrine disorders, and infectious processes. So I know in the emergency department, I've taken care of a couple different patients that all of a sudden were hallucinating for no reason. And unfortunately, when we did a CT scan, they had a big mass in their brain and it was pressing up in their brain. And our brains don't like things pressing on it in that confined space, and it caused the symptoms. I know I've seen problems with endocrine disorders as well, where people's thyroid is way out of whack and they're just going 100 miles a minute. Unfortunately, this can cause some psychosis as well. We know that infectious processes like HIV, or the little old lady with the UTI, or even syphilis, that used to be the thing. People used to think that people with syphilis were crazy because of the neuro symptoms. So with that in mind, we always need to be getting a complete blood count, metabolic profile, thyroid test, and serological tests for infection. We also need to not rule out cognitive delays and co-occurring or premorbid conditions, including ADHD, disruptive behavior disorders, and anxiety and mood disorders. So just because someone has schizophrenia doesn't mean they don't have ADHD or other things. And we always need to remember that when we're assessing a psychotic patient, we need to match our interviewing style with the needs of the patient, as often those with psychosis ramble, are disorganized, and appear to have an illogical thought process. A lot of times, they're tangential, they don't make a whole lot of sense, and we just need to be patient with them in order to get our assessment information. And then we always need to keep our safety in mind, because unfortunately those that are psychotic, in my clinical practice, I found those that are manic and schizophrenic tend to be the most unpredictable. Thinking back on a patient I took care of that was coming in for evaluation of his schizophrenia, his long-standing schizophrenia, he was polite, he was friendly, he wasn't always making a whole lot of sense, but when I went to go take him to the locked area, the locked room, I got him kind of situated on the bed, and all of a sudden he charged at me just randomly, unprovoked. Unfortunately, he was really paranoid. I didn't know he was paranoid, and his brain just said, he was in danger. So we just need to keep this in mind. I think our Shea textbook really stressed this important fact too last semester. So some examples of some potential questions for assessment of psychotic symptoms. Do you ever feel as if other people can read your mind or hear your thoughts? I think one of the most successful questions I've seen in the ED is, do you have any superpowers, or do you have any special abilities? For some reason, a lot of times they're very excited to tell you about that, whether it's laser beams or things like that, whether they can fly. I've seen all of those in the ED. Do you have a lot of worries or things on your mind? Can you tell me what those are? So maybe those are going to be better for the prodromal patient. Do these things interfere with your ability to do your usual routine or activities? Do you ever feel like people are out to get you or have it in for you? I think a lot of times people that are paranoid, this is what happens, right? They're worried that the license plates, I've seen that quite a bit, where people are saying that license plates are talking to them and only messages that are meant for them. Do you ever hear sounds or voices when you're alone or when no one else is around? Do you ever feel like your mind plays tricks on you? And do you have a special relationship with God? I think all of us know that a lot of times our acutely psychotic patients feel like they have this special relationship with God. A lot of times they feel like they're on a mission, so on and so forth. So, for psychosis, we have a whole bunch of clinical assessment tools. We have the clinician related dimensions of psychosis symptom severity scale. We have the World Health Organization Disability Assessment Schedule, which helps determine the level of disability. We have the Brief Psychiatric Rating Scale, which is a 24-item scale rated from 1 to 7 to rate severity of symptoms, including anxiety, depression, hostility, and hallucinations. We have the Positive and Negative Syndrome Scale, which is a standard tool for assessment of schizophrenia, measuring 30 positive and negative symptoms. And then we have the Calgary Depression Scale for schizophrenia, which measures depression and the presence of schizophrenia. I think something that's super important to really stress in this presentation is, unfortunately, 13% of schizophrenic patients die of suicide. So just because they're schizophrenic doesn't mean we don't need to really pay attention to those other pieces. We need to always be assessing their depression, their suicidality, their safety, using our clinical gut to make sure our schizophrenic patients are safe, right? So we have all of these clinical assessment tools that are widely available online that we can use to put a number to some of these symptoms to see how people are progressing over time. Especially in our notes, insurance companies really like to see that progression over time, and I think that's very important to always have in your back pocket and to keep in mind. So, for a diagnosis of schizophrenia, according to the DSM, you need 2 or more of the following, each present for a significant period of time during a 1-month period. Remember, it has to be at least 1 month. And you need to have at least 1, 2, or 3, at least bullet number 1, bullet 2, or bullet 3. So you need to have delusions, hallucinations, or disorganized speech. And then you also need, you could have one of these other ones, grossly disorganized or catatonic behavior, negative symptoms. So you need 2 or more of the following, and you need at least 1 of the delusions, hallucinations, or disorganized speech. So, diagnosing other psychotic disorders. So, just like there's other medical conditions that can cause schizophrenia, there are other psychiatric conditions that can cause psychosis, and we always need to be keeping that in mind for our differential diagnoses. So, we have delusional disorder, which is characterized by non-bizarre delusions. So, no matter what I find out, essentially, it's this firm belief that, maybe my husband's cheating on me, and no one can convince me otherwise. That's a pretty rational belief, right? That could be happening. As a nurse that's caring for me, maybe you think, oh, maybe his husband is cheating on him. So, a lot of times, unfortunately, with schizophrenia, it just doesn't make any sense. But with delusional disorder, it's a lack of impaired functioning and these delusions that could possibly make sense. We have brief psychotic disorder, which is a sudden psychotic episode for at least a day, but no longer than a month. So it's short term, because we know in schizophrenia, unfortunately, this is a progressive and debilitating illness. It doesn't just reverse. So with the brief psychotic disorder, this is just a short term stint. And then we have schizoaffective disorder, which is characterized, of a thought disorder and a mood disorder, and patients usually recover. And then we have schizophreniform disorder, which is symptoms of schizophrenia. The patient recovers from the symptoms of schizophrenia within 6 months, but symptoms last at least 1 month. So it's a little longer than that brief psychotic disorder a lot of times, but it's not a continuing problem for them. So differential diagnoses. For schizophrenia, we always need to be keeping in the back of our mind, like we mentioned, the psychiatric disorders and the medical conditions. We also need to be keeping in the back of our mind psychosocial factors, abuse or neglect, traumatic stress, or even secondary gain for reporting. I think some of the most psychotic patients I've ever taken care of are refugees. And a lot of times it's thought that abuse or that, the lack of nutrients, the lack of food, being from war-torn countries, all of those sorts of other things put stress on the brain and maybe cause, certain genes to turn on, turn off, change, cause abnormalities in the brain, those sorts of things. And like we talked about, we need to pay attention to those medical conditions as well. We all know that, drinkers, unfortunately, when they're going through withdrawals, can see things, hear things. We also know from delirium, brain neoplasms, encephalitis, AIDS, seizures. It's always really important to ask about head injuries and seizures to determine if maybe there's some brain damage that was done. Electrolyte imbalances, we know that can cause some psychosis as well. Blood glucose abnormalities. This is the reason when someone comes into the ED, we always check a glucose right away if they're worried about a stroke, because it can cause cognitive changes. And then the endocrine abnormalities that we talked about, the high TSH or the changes in T3, T4, all of those sorts of things. So just a reminder to keep in mind the psychiatric disorders as well as the medical psychosocial factors that also come together to cause schizophrenia. So treatment of schizophrenia. So what as APRNs will we be able to do to help people with schizophrenia and psychosis? A lot of times it has been discovered that antipsychotics combined with psychosocial interventions are the treatment of choice. So we'll go over the algorithms here in a little bit, but a lot of times it's the second generation antipsychotics combined with certain types of therapy that have been found to best help people. There's also growing evidence that guidelines really improve patient outcomes. If we follow algorithms, if we have a very detailed plan of care that someone else can follow, we're really able to help people in the best way possible. So we're not just picking a medicine willy-nilly. We have a rationale for it. We know where we're going to go. If this doesn't work, this doesn't work, this doesn't work, and other professionals can follow our train of thought. So it's that standardizing of care can really help those with schizophrenia in making sure that they get the help that they deserve. So, another thing that y'all probably thought you would never see again, but surprise, the Katie trial. So we all know how cool the Katie trial was. So this was a landmark trial that studied the efficacy, side effect profiles, and effectiveness of perfenazine as well as second generation antipsychotics. So they compared perfenazine with the second generation antipsychotics, a whole bunch of them, in how they worked and side effect profiles. The cool thing about the Katie trial is they tried to model the real world. They took a whole bunch of different types of people. They didn't have a lot of exclusion criteria, and it took place in a whole bunch of large variety of treatment settings. One of the sad things that they found out that people with schizophrenia tend to discontinue their medications at a high rate. So this is something we definitely need to keep in mind with our schizophrenic patients. Do they belong on a long-acting injectable? Does this help them control their schizophrenia better than an oral medication because they get better and then they go off of them? The Katie trial also outlined how olanzapine seemed to be very effective but caused a lot of side effects. And I think all of us have taken care of a patient that's gained 50, 100, 120 pounds on Seroquel. A lot of people, it's so uncomfortable because they want to eat all the time. So the Katie trial kind of confirmed that. The big breakthrough with the Katie trial was there was no significant differences in effectiveness between perfenazine as the prototypical first generation and second generation antipsychotics in effectiveness. So, neither generation worked better than the other and neither had worse side effects from the other. So that was really huge. And I think a lot of people tend to think, the second generation worked better. Well, that's not actually true. So we have a schizophrenic patient and we need to decide what to do with them. So we have a decision tree for treatment initiation, and this is from your TUSE textbook. So someone comes into our office and they have psychotic symptoms. So we need to go down that branch of the decision tree and we need to decide whether it's medical, neurological, or a systemic illness, or maybe it's related to a mood disorder. If it is one of those things, you need to treat those things individually. If it's not, then we know it's a primary psychosis, and then it can be one of these other 3 different branches that the provider would then go down. So if you haven't read the TUSE textbook yet, it's really great in just walking you step by step by step in what to do if somebody is psychotic or if you suspect they have schizophrenia. So this is the treatment algorithm per se. So if we do decide to start treatment, when we go down that algorithm and it's decided that treatment is necessary, we have a whole bunch of different antipsychotic medications, and they can be broken down a lot of times into low potency and high potency agents. So low potency agents being our Seroquels, our high potency agents being Haldol, olanzapine, risperidone, ziprasidone, Abilify, Latuda, and Rexulti. We don't see a whole lot of flurfenazine and a couple other medications like that used, more the high potency agents, but we do see, risperidone and ziprasidone. The cool thing about our textbook and Toussaint, with all these different medications, they have little clinical tips. So say you're going to prescribe, Seroquel for a patient, well, make sure you're monitoring metabolic syndrome. And then, olanzapine, make sure you're monitoring metabolic syndrome and the body's ability to control temperature. So there's little clinical tidbits with all the low potency and high potency agents. They can also be broken down into whether they're first generation or second generation antipsychotics, but that's not how the book breaks it down, so I necessarily won't get into that. So once we've used our treatment algorithm and decided it's appropriate to treat with an antipsychotic, we can use this algorithm and go to stage 1. So stage 1 with the first episode or newer, Psychosis is a trial of a single second generation antipsychotic, most typically olanzapine, Seroquel, risperidone, and ziprasidone. I don't think a lot of times we'll start with Seroquel, and it's not even recommended. You'll see that in one of the next few slides just because of the major side effects, and then people don't stay on it. Say they have a partial or no response to that, trial the single second generation antipsychotic. If partial no response to that, you go to stage 2A, which is a trial of another single agent, whether it's a first generation or a second generation. So this is where the Toussaint text recommends pulling in the first generation. And say there's no partial or no response to that. Well, we all know that clozapine is approved for treatment-resistant depression, but it has the leukocytosis problem. So we know that this is stage 3 for no response, where we jump into clozapine. Say there's even no response to clozapine, which you don't see a whole lot of writing about that, but then we are going to try clozapine and a first generation or a second generation or even ECT. There's some really good results with ECT in psychosis even. And then finally, stage 5, trial a single agent, again for the first generation or second generation. So this is just the algorithm you would go through in order to choose your antipsychotic medication. So, what are the different phases of schizophrenia? We have the acute phase that we talked about, and how do we treat that? For this, we're going to use an antipsychotic medication, and we're going to basically pick that a lot of times based on individual preference by the person. So it's a cost-benefit analysis with the person. We want to get their buy-in. Our number one concern is that they're treated and that they stay on the medication, while keeping in mind relevant medical history, risk factors, individual medication side effect profile, and long-term treatment planning. So essentially, get them on an antipsychotic according to the previous algorithm. In the maintenance phase, people with treatment-responsive multi-episode schizophrenia with sustained relief with an antipsychotic should be offered continued antipsychotic treatment in order to maintain symptom relief. So make sure that they stay on their antipsychotic. We should offer them a long-acting injectable. Should be offered as an alternative to oral antipsychotic medication if they would like. So the authors really just want to stress that in the maintenance phase, you just don't always keep them on the oral medication. Make sure you're offering a long-acting injectable, especially if you think they may not continue their medication. And then finally, clozapine should be offered to people with schizophrenia who continue to experience persistent and clinically significant positive symptoms after 2 adequate trials of other antipsychotic agents. A trial of clozapine should be at least 8 or 9 weeks at a dose between 300 to 800 milligrams. So essentially, the authors just want to stress here that once you've gotten through the acute phase, make sure you continue to treat the illness, Make sure that you're providing patient-centered care, and then if they'd rather having long-acting injectable, you get them that. And then if they're still having symptoms, you make sure that clozapine is offered. Some medication considerations from our TUSAE textbook. An adequate trial of antipsychotics according to our algorithm is at least 3 weeks, but as we mentioned, clozapine can take up to 3 months to take full effect. 9 weeks is kind of more of the gold standard, which should be considered as an adequate trial of antipsychotics. Now, we know that antipsychotics are powerful medications, so we have some pediatric considerations as well as some geriatric considerations for the medications. So for the pediatric considerations, it's generally thought, according to our text, to say second-generation antipsychotics are considered the first-line therapy in most clinical settings due to decreased risk for EPS as well as tardive dyskinesia, so those movement side effects. In pediatric psychiatry, I tend to see a lot of Seroquel. I see a lot of Latuda, some of these ones that have less of the movement side effects. We know with children, it's important to start doses low and increase slowly, and it's important to monitor for early signs of TD. For geriatric special considerations, it's also important to start at a low dose and go slow. It's important to also consider their kidney and liver function, right? So we know that kidney and liver function are going to decrease. So we need to keep in mind that drugs metabolized by CYP3A4, such as Seroquel, ziprasidone, and haloperidol, this clearance declines with age. We also know, and I think this is a huge one that everyone needs to keep in mind, the elderly are more sensitive to anticholinergic symptoms as well as orthostatic hypotension. So if I see a little old lady that's, 85 and she's been falling and she's still on all of her antipsychotics, kind of makes me nervous that, she might fall again, right? So when she gets up, she needs to be educated on the importance of getting up slowly, certain other things, because her body just can't adapt the way a young person's body can adapt. We also know when prescribing antipsychotics that there's a high incidence of TD in the elderly with conventional antipsychotics. I was just taking care of a 55-year-old lady not too long ago, and she had long-standing bipolar and, just lots of lip smacking. Her neck kind of kept moving, her trunk kind of moved. We've all taken care of those people that you just know have been on conventional antipsychotics for maybe too long. We also know that Haldol is notorious for this. I don't see a whole lot of Haldol anymore just because it can cause a lot of these side effects. So, speaking of all of these side effects, how do we manage the side effects, and what are these side effects? So, one of the most dangerous and scary ones is neuroleptic malignant syndrome. So, this is a lot of times includes hyperthermia, severe rigidity, hypermetabolism, labile blood pressure, all of those sorts of things. It is thought that this is due to a life-threatening condition and as a result of dopamine blockade. And for all of you in the ICU and EDs, you'll know that dantrolene is a lot of times used to treat this. Also, for you nurses that maybe have some ED experience, then you've seen a lot of serotonin syndrome. So this is due to an excess of serotonin in the bloodstream, and a lot of time results in fever, agitation, and jerking motions. Main thing that you see is they are just super anxious when I see them in the ED. They cannot sit still. They can't think straight. They are just a little bit, for lack of a better word, a hot mess. And you always need to keep in mind that there's just an insanely dangerous risk for serotonin syndrome with the MAOIs mixed with an SSRI. So just keep that in mind when you're prescribing, and it gets to be a little bit of a polypharmacy situation. So some of the other side effects for antipsychotics, we have extrapyramidal side effects, including a variety of signs and symptoms that are more common in the first generation antipsychotics compared to the second generation antipsychotics. Most often involves the EPS, potentially all muscles under voluntary control, can be exacerbated by anxiety, and can sometimes get better with sleep. Sometimes they can happen earlier in treatment or late in treatment, but usually takes at least a couple weeks. A lot of times they involve the face, head, and neck, and one of the really interesting things from our text is young men are more at risk with the traditional antipsychotics. My preceptor really likes to stress that we always need to watch young boys and young teenagers as they transition from being a child and go past puberty. The risk for these EPS side effects really go up, and we need to make sure we're possibly titrating the medications down to make sure they don't have EPS side effects. She likes to state that Abilify is notorious for this with teenage boys, that as they finish puberty, they really have problems with it. I don't know, I haven't read the research on that, but I trust your judgment on that. And then we all know the dreaded tardive dyskinesia that all of us are probably scared of when we graduate and pass boards. This is more of a late onset EPS and involves involuntary movement disorders that are non-rhythmic, repetitive, and often purposeless. And they usually involve the orofacial lingual musculature, including chewing or twisting of the tongue, movements of the fingers, hands, or lower extremities. Sometimes this can be so bad that it impacts activities of daily living, and people are really self-conscious about how they appear in the world. Maybe they have a hard time getting shirts on, those sorts of things. May be irreversible, even though there is an FDA-approved medication for it. I've never seen it used, though. So, as prescribers, it's really important to monitor using the AIM scale whenever you have a patient on an antipsychotic medication. I think it is a little harder with telepsych to see some of these fine movements, but it's still important to document that you did this, that you're tracking this, especially if they are showing symptoms. So, other considerations in prescribing antipsychotics and prescribing medications for psychosis and schizophrenia. Remember that prescribing antipsychotics is a risk-benefit analysis, and this should always be done with your patient in order for them to truly understand the risks and the potential benefits of the medication. Be careful with polypharmacy, because a lot of times these are the more sick patients, and a lot of times they'll be on multiple agents, so just make sure they're not interacting with each other. Be careful with Tegretol, because this can impact antipsychotic metabolism for other medications. Be careful with lithium. A lot of times lithium at high levels with an antipsychotic at high levels can have a synergistic effect. So that would be particularly important to note if you have an older person per se and you're monitoring for that orthostatic hypotension, etc. There is lithium-induced neurological side effects that can occur. So all of us have taken care of the patient that's on lithium and they have that lithium tremor, right? And from a mile away that they're on lithium, at least you do as a psych nurse, because you can kind of notice that lithium tremor. So there is, neurological side effects of lithium, and a lot of times lithium is used with the antipsychotics. And I thought this one was really interesting. The author Toussé recommends being mindful of the abuse of Seroquel and the antipsychotics in general. They make the argument essentially that a lot of these medications have anticholinergic properties that make them abusable. You can get a little high off of them if you snort them, and they cite Seroquel. I thought this was interesting because we use a lot of Seroquel in pediatrics with teenagers. So something I have to keep in the back of my mind if maybe they've had drug problems or parents have drug problems, because we know that drug problems tend to be genetic. So now that you are all full of knowledge about psychosis, what can cause it, about schizophrenia, the various stages, and how to treat it, the questions for today. So I would like you to answer one of the three questions. Describe a recent patient you took care of with acute and primary psychosis, including the mental status exam, and describe the appropriate differential diagnoses, essentially, that you ruled out, and your choice of a first-line pharmacological agent. I would like you to go back and use that algorithm that we just spoke about. And how did you rule out a medical cause for this psychosis? Next up, I thought this was interesting because it's one of my fears of prescribing antipsychotics. Movement disorders are a scary reality of prescribing antipsychotic medications. Describe how you will minimize the risk of movement disorders in your practice and how you'll monitor for it. What do you think of the use of Ingrezza in treating tardive dyskinesia? Have any of you seen it? I would be super interested to see if anybody has seen it in practice. I would love you to answer number 2 if you've seen it. I haven't seen it, so I'm excited to kind of hear about this one. Lastly, think back on a patient you took care of with schizophrenia or probable schizophrenia. schizophrenia. How was their schizophrenia treated? Describe the stage of schizophrenia they were in and how you provided that patient with holistic, patient-centered care. So I basically want you to think about this patient and compare and contrast the treatment algorithms, etc., that we talked about in this presentation with this patient, and whether you would have done things differently now that you know this information, or whether it was exactly by the book per se. Thank you, everybody. I really look forward to this week's discussion, and if you have any questions in general, let me know.